Hi, my name is Anita Farley. I am a registered nurse, and today I am going to be teaching you how to do major autohemotherapy, otherwise known as IV Ozone. So I have a few different supplies here that I'm going to review with you that you'll need in order to do the procedure. The first one here is a TPN compounder bag. What this is an empty bag that we will actually put some of our normal saline into in order to do the treatment, which I will show you that in just a minute. I do have IV tubing. This is plain IV tubing without a filter. And you can also use blood tubing that has a filter as well. I do have a bag of normal saline here, 500 cc bag. I've got IV start kit. One of those people frequently ask me is what kind of catheters do we use? So this is a 20 gauge blood control catheter. It's usually best if you use a 20 gauge catheter. On occasion, if you have to use a 22 gauge catheter because someone has smaller veins, that's okay. I wouldn't go much smaller than a 22 gauge. Other supplies I have here, this is actually an ozone safe syringe, and I'll explain that why that's important when we get to that stage, but this is a 60 cc silicone-based ozone safe syringe that we will use to collect our ozone gas with. And then finally, I have heparin here. This particular heparin that I have is 1,000 units per ml heparin, and the protocol for IV ozone calls for 2,000 units to 5,000 units of heparin. So we have our heparin here. The first thing that I'm going to do to show you how to prepare is we're going to actually prepare our bag of normal saline. And how we're going to do that is take our bag of the fluids that we have, and what we want to do is transfer 120 cc's of the normal saline into our TPN compounder bag. So this TPN compounder bag essentially is an empty bag. This one has a volume of 500 milliliters. You would not want to do smaller than a 500 milliliter bag. At the end of this, it has a spike adapter, and then it has some closing apparatuses here. It also has a port where we'll eventually put our IV tubing in for our infusion, as well as an administration port. So the first thing I'm actually going to do is take off my plug there for my saline, and I'm going to use my administration or my spike adapter here, and I'm going to put that into my tubing, my port here, as if I was doing IV tubing and priming my bag. But instead what I'm doing is transferring fluid from this bag into this TPN compounder bag. My goal is to have 120 cc's of normal saline in this bag. So I'm going to take a peek here. Not quite there. So I want to use our reserve, and this is really just so that when we do the procedure, we are diluting some of the blood that we're going to collect from the patient. And that's why we want to start with about 120 cc's of normal saline. I overfilled it just a little bit, so now we just flip it over. And when we get to about 120 cc's, and this is an approximate, it's really hard in a bag like this to have like exactly 120 cc's. So I'm going to now put this bag on my pole. I want to clamp this shut, and now I can remove the original bag and just set that aside. Okay, so I've got my bag of 120 cc's of saline. The next thing that I want to do is add heparin to that bag. So as I said, I'm using 1,000 units per ml heparin, and the protocol calls for 2,000 to 5,000 units of heparin. This is definitely provider discretion if they want to go to the higher end or the lower end. In my experience, 2,000 units is appropriate, and we don't usually have clotting issues when we do the actual infusion. But everyone's a little bit different, and The only time that I would use a larger volume of heparin would be if I was using a blood filter tubing, so that it really helps keep that line patent. So I took out 2 mLs because this was a 2,000 units per ml or 1,000 unit per ml. And then next I'm going to add that to my bag of normal saline. And this way we have a nice mix of saline plus heparin. So kind of mix that in there. And then the next stage that we're going to do is prime our IV bag. So I've got my tubing here. And the reason that we use heparin is it doesn't actually have anything to do with ozone therapy itself. What the heparin does is it will keep this system clear from any clots. So we're going to be collecting blood from the patient. And while the blood is exterior to the patient, we want to make sure that it doesn't clot in this system. So we use the heparin for that purpose only. So it doesn't actually have any mechanisms of action for the ozone therapy itself. So I'm going to go ahead and prime that tubing. And now I am ready to move forward in the next step, which is to establish an IV in my patient. A common question that people ask me is, do I have to use the TPN compounder bag? And the answer is no. So the TPN compounder bags are great if you're doing multiple infusions that day, because you could take one 500 milliliter bag and fill up 4 of these TPN smaller bags. However, if you have just one patient coming in that day, or you're mobile, for example, what I found to be extremely helpful is that I just take a 500 cc bag of fluid. I go ahead and prime that with my tubing. I start my IV on the patient, and I go ahead and infuse that patient with 380 mLs of fluid first. So that at the 120 mark, I usually take a Sharpie and I just do a little mark here saying that at 120, I'm going to stop my only saline infusion, clamp my bag, and then move forward with the next step in the process, which in this case would be adding my heparin to the residual of that 120 cc's of normal saline. I'd add my 2,000 units of heparin here, and then I would move forward to the next step in the process. So next we are going to actually establish an IV in the patient. So I'm going to go ahead and get her tourniquet on. And then we're going to use our IV start kit to prep the area. And as I said before, we're actually going to use a 20 gauge blood control catheter. And do a little poke here. And then we're going to grab our IV tubing and we're going to connect it. However, we are not going to turn on our fluids yet. So we're going to connect our tubing. Make sure that this connection is really tight because we definitely need to make sure that there is no loose connections here at the site, and I'll explain that why in just a minute when we get into troubleshooting. Go ahead and get that on, and then next I'm going to actually grab my IV bag. So now I'm going to take the bag off of the pole. I'm going to take it below the patient's heart. I use a tray here with Chuck's drape over it. So now we have our roller clamp on our tubing. We're going to go ahead and unroller clamp that. And what you're going to see is the blood backfilling by gravity into the tubing and ultimately collecting into our bag. What our goal is with the major autohemotherapy protocol is we started with 120 cc's of normal saline. We've added 2,000 units heparin. And now we are going to collect 200 milliliters of blood from our patient. This is done by gravity, and it should take about 10 or 15 minutes to collect the 200 milliliters of blood that we need into our bag system here. So what I usually do is just check every once in a while to see if I'm collecting blood. And you should have a consistent drainage. Couple of troubleshooting tips. If you started your IV, everything was running, but the blood was coming really slow out of the patient. A couple of tips that you can do to help get that blood flowing a little bit faster is, number one, check your connections at your site. If they're loose at all between that hub and your tubing, that could be why it's running slow. Second tip is to take your tourniquet and do just a little tight, not even the same that when you started your IV, but just a little tension above her IV site here to give it a little tension down on that catheter site. You can also ask the patient if you have a ball, or they can just squeeze their hand and do that like about every 30 seconds to keep that flow going. And then lastly, you can actually ask the patient to just stand up for a second, maybe march in place for a second, and then sit back down. Because sometimes we just need help to get the blood to start to collect by gravity. So ultimately though, what you're doing is a goal of collecting 200 milliliters of blood into your bag here. And when you've got 320 milliliters in your bag now, that's when you're finished collecting. So we had 120 to start, and then we're going to end at 320 because we're going to collect 200 milliliters of blood. While your patient is collecting the blood that you need, the 200 milliliters, the next thing that we're going to do is go to our ozone generator and collect our ozone gas. So just again, a quick summary, we did 120 cc's of normal saline, 200 milliliters of the patient's blood, and now we're going to collect 200 milliliters of ozone gas. The only thing different per patient is going to be the dose of the gas that we're going to collect. That's the only unique part for the total infusion process. The ozone gas unit of measurement is gamma, and so typically we have a range of 30 gamma to 70 gamma. When you look at your protocol, there's a reference guide in your protocol for when would you give 30 gamma versus when would you give 50 gamma, and then when would you give 70 gamma. And in that protocol, it's very easy to understand. Also that if you start at 30 gamma, for example, you're going to do a series of infusions for your patients. So if you start at 30 gamma and the patient tolerates that well on their first infusion, the next infusion, you're going to increase your gamma by about 5 to 10 gamma. So then you would be doing 40 gamma. Now your ozone generator is going to have a graph or a tool for you to figure out how to collect the gamma that you need for your procedure. Today, for example, I have a patient who has been receiving ozone fairly routinely. She gets ozone at least once or twice a week. And so with her, we are going to give her the max dose, which is 70 gamma of the ozone gas. And we're going to collect that gas with 60 cc ozone safe syringes. And then the other supply that I have here, and I'll show you how I use that in a minute, but this is a 23 gauge butterfly phlebotomy needle. So I'll show you why we use this in the next step. So firstly though, our ozone generator should be sitting tabletop. Oxygen tank is sitting behind it, and we have an oxygen tank regulator on that tank. And we have our oxygen tubing that runs from our oxygen tank to the oxygen insertion site in the generator that you're using. The oxygen, when we turn this on, is actually going to be fed into the generator. The generator is actually going to break up those oxygen O2 molecules into single oxygen atoms and then reform them into O3 atoms. And when we have our O3 out site, that's where we're going to collect our O3 out at the gamma that we set the generator at. So what I'm going to do here is turn on my oxygen first, and I've got a dial back here also. So I'm going to turn on my oxygen on according to the instructions of my ozone generator. And then the next thing I am going to do is, now that the generator is creating the ozone gas, what I have here is, this is where the O3 is coming out. This is called a syringe fill system. This is silicone based, and this is a metal destruct. So any residual ozone gas that's in the system will go into this metal destruct, not into the atmospheric air where I would potentially breathe it in. And then I'm going to grab my first ozone syringe. On the end of this, there is a stopcock. So I'm going to put my syringe on my stopcock, turn my stopcock towards the destruct, and then when there's enough pressure built up in this tubing, that ozone gas will autofill my syringe here. You can see that it's autofilling the syringe here now. So slowly we're going to fill up 3 full syringes at 60 cc's of ozone gas at the set gamma that we chose. And then we're going to do our 4th syringe at 20 cc's so that we have a total volume of 200 milliliters of gas. Now, the next thing that we want to do is set our syringes upright. Ozone gas is clear and colorless. And so what we want to do is when we set the syringe up, we want it to be sitting upright so that that gas settles to the bottom. And then we don't have any escape, so that when we actually go to add that ozone gas to our bag of blood, heparin, saline mix, we have the maximum of the ozone gas in that. One quick tip. When you're doing your ozone collection, be sure that your oxygen tank regulator gets turned off. A lot of times we collect our ozone gas, we get our 200 milliliters, we're good to go, but we forget to turn off this oxygen regulator. What happens is the oxygen will continue to flow out of this tank. The next time you go to do an ozone infusion, you go to collect your ozone gas and you are out of oxygen. So that's just a helpful tip to always remember to teach the staff to make sure they turn on the oxygen, collect their gas, turn off the oxygen, and then they can turn off their generator. This last part is where we're actually going to add the collected ozone gas to our bag of heparin, saline, and blood mixture. And as I said, we have 200 milliliters. So we have 3 60 cc syringes at full and 1 at 20. And then I have here a phlebotomy needle. It's a 23 gauge phlebotomy butterfly needle, and on the end of it has an extension. And we're going to use that extension because that's how we're going to attach our syringe here. So the first thing I'm going to do is take my first syringe, luer lock it here with my butterfly needle. And this is how I'm actually going to push the ozone gas into my fluid collection bag here. So we're going to stick that up into our admin port. Now, the reason that we use a 23 gauge is if we had a really large lumen needle on the end of this, the blood from this bag will backfill into our tube and ultimately down into our syringe. So we don't want to contaminate our syringe. And so that's why we recommend 23 gauge, 25 gauge, 27 gauge, so that you don't risk that blood coming back and coming into your syringe. So one at a time, I am going to attach each of my syringes, pushing that ozone gas, and you can see that it's bubbling up into the bag. Once the ozone gas actually enters the bag, it is no longer a gas. It'll immediately interact with the patient's plasma and their hemoglobin, and it is then converted into ozonides. And ozonides are actually the hormetic oxidative therapy that we're giving to the patient. And so if your patient is concerned at all that there's gas that might be going into them, be sure to let them know that the gas disappears. Okay, so we've added all 200 milliliters of our ozone gas. So then we're going to just remove our butterfly needle here. And this, of course, goes into our sharps container. And then lastly, now we have this mixture of the patient's blood, saline, heparin, and ozone gas. What we want to do next is do a gentle rocking of this entire bag so that we mix all of that ozone gas and turn it into the ozonides. That ultimately is what we're infusing into the patient. A couple of tips here. When the bag was below the patient's heart and it was collecting her blood, this drip chamber got really full because it was collecting backwards. So what we want to do is clear out some of that fluid from that drip chamber. If you actually kind of tweak the end of the tubing there, put your bag upside down and squeeze your drip chamber, that will clear some of that blood from your drip chamber, and now it's a little bit less full. So usually you want to rock this bag, nice gentle rocking, about 1 minute. And what happens is that the ozonides actually brighten the blood. You can actually see how the blood is getting a bit brighter of a red than what was originally coming out of the patient. So we do that for, like I said, 30 to 60 seconds. And then next, we're going to put it back on our pole, and we can open up our roller clamp and start re-infusing our mixture into the patient. The patient may feel a little coolness at their site when that mixture starts hitting their bloodstream. A couple other troubleshooting tips here. Because this drip chamber was completely full, now that the bag is dripping into the drip chamber, we are traditionally looking for drip, drip, drip from that drip chamber into this collection container. Because we had wetness all the way around this drip chamber, what's happening is that blood is likely catching to the side of the drip chamber and traveling down the side of it. So you may not see that an actual drip, drip, drip immediately when you restart your infusion. So what you're going to do is monitor your level of the volume and ultimately watch to make sure that it is dripping back into the patient. If for any reason you have concern that it's not draining into the patient, the next thing that we're going to do is actually troubleshoot our administration line and our IV site. If you have any consideration or concern that possibly the fluid is not running into the patient, maybe the bag hasn't moved down in level at all, the next thing that you want to do is troubleshoot your line and your catheter. So I have here a 10 cc syringe, a needle, and an alcohol pad. And what I want to do is first assess from the patient, from my administration port towards the patient, and make sure that I can pull back easy with resistance, that I can flush a little bit into that port. And then second, I am going to assess the distance between my administration port and back into my tubing. Sometimes what happens is a little teeny clot or something gets wedged up in the tubing. So we just want to flush that system and make sure that we have a patent line. If for any reason you find when you're doing this that your line tubing is clotted, I do recommend at that point that you're going to change out your entire tubing. So we'll talk about that in a second, but the first thing I'm going to do is I'm actually going to collect some of the fluid from this bag here. I've clamped between the patient and my port, and I'm just collecting straight from the bag. And it's collecting pretty easy, nice and smooth. So then the next thing I'm going to do is clamp after or before that, so that I can also now, I'm gonna just pull back a little bit on the patient's site. I didn't get any blood immediately, and it's hard to see if you're getting actual blood return, but I'm gonna try flushing a little bit in there, and I'm meeting no resistance. It's flushing very easily. She should feel some coolness as I'm flushing this. Yep. And so you can see that I've checked that it's running both between the bag to my port and then my port to my patient. If for some reason, as I said, there was a tiny, we had resistance pushing that in towards the patient, there could potentially have created a tiny microclot here at her catheter site. If that happened, then I would actually be looking to start an IV at a different site. I would be proactive in changing out my IV tubing, repriming that bag of fluid with new IV tubing, starting a new site, attaching it over there, and allowing that ozonated blood to get back returned to the patient. So that's the most common troubleshooting situation you have when you're re-infusing the infusion is a little clot in your line, which you're going to change your tubing, or if you have a clot at the site, you're going to change your whole access site. Go ahead and change your tubing with that, start fresh, and then go ahead and hang that. The reality is that happens not that often. So we're talking about, 1 or 2% of infusions might have that happen. Another tip that I have to prevent that or mitigate that is if you're collecting blood from the patient, and as I said, it should take about 10 minutes to collect the 200 milliliters, 15 max. If you have someone who's blood collecting super slow, my recommendation is at 15 minutes, stop collecting. If you have 150 cc's of blood at that point, move forward. Don't continue to try to collect for the next 10 or 15 minutes. The longer the blood is outside of the body, the higher risk that it's going to clot. So stop it at 15 minutes, work with the volume of blood that you've collected. Remember that you had 120 cc's to start with. And then when you go to the ozone generator to collect your gas, collect 1-to-1 to blood collected. So if you got the full 200 milliliters, collect 200 milliliters at the gamma that you need. If you only were able to collect 150 milliliters of blood, collect your ozone gas to meet that at 1-to-1. So you would collect 150 milliliters of ozone gas. And that way you don't risk having to do troubleshooting with the line and causing preventing any clots in that tubing. So just a quick review of everything we did today. We started with a bag of normal saline, 120 cc's. We added 2,000 units of heparin. The protocol calls for 2,000 to 5,000. That's provider discretion. We primed that tubing. We attached it to the catheter hub of the IV that we started. And then we lowered that bag below the patient's heart and collected 200 milliliters of blood. That part takes about 10 or 15 minutes. Then we went and collected our 200 milliliters of ozone gas at the gamma that is clinically indicated for our patient. So refer to your protocol for that. We added the ozone gas to our bag of fluid with our 60 cc syringes using our butterfly phlebotomy needle. We slowly rocked that so the ozone gas mixes with the blood and turns into ozonides, and then we reinfuse the infusion. The entire process from beginning to end of infusion completion is about 45 minutes. And people often ask me, how fast should I drip the infusion back? I just open it so that infusion rate is open, allowing gravity to infuse that ozone blood back into the patient. And then finally, when the infusion is complete, we do our traditional gauze pad to disconnect our IV tubing, our Coban to disconnect our IV tubing, and your ozone infusion is complete.